Today we're going to be taking a look at intrarenal acute kidney injury as part of the renal series. To start this topic, we're first going to define what we mean by an acute kidney injury, and in essence it refers to a sudden increase in serum creatinine, or a sudden decline in urine output. The reason why we tend to use serum creatinine as a marker for renal function is because it's a product of muscle breakdown, and importantly, it's freely filtered into the kidneys and not reabsorbed into the blood. In clinical practice, we tend to use the KDIGO classification, which helps to define AKIs in more specific terms. For instance, if a patient has an increase of serum creatinine of greater than 26.5 micromoles per liter in the last 48 hours, this would be defined as an AKI. Alternatively, if the patient has a baseline creatinine, and then the levels of creatinine are 1.5 times or more greater than this baseline, this would also qualify for an acute kidney injury, as long as it happened within a 1-week time frame. Additionally, we can also take a look at urine output, and if this falls below 0.5 milliliters per kilogram per hour for more than 6 hours, this would also match the criteria for an AKI. If any of these features are present, we can confirm the diagnosis of an acute kidney injury, and we can divide AKIs into different stages depending on the level of rise of serum creatinine. The other aspect to understand is the basic anatomy surrounding the urinary tract system, and this is primarily composed of the kidneys, which produce the urine, the ureters, which transfer the urine, and the bladder, which acts as a storage space. In terms of the blood supply, unfiltered blood enters the kidneys via branches of the renal artery, and then the filtered products return to the blood via the renal vein. One way of thinking about acute kidney injury is that something can go wrong with each stage of this process. For example, we could have a prerenal AKI, where there's an issue with perfusion to the kidneys. We could have an intrarenal AKI, where there's direct structural damage, or we could have a postrenal AKI, where there's an issue with obstruction of the urinary tract output. In this video, we're mainly going to be focusing on the intrarenal causes of acute kidney injury. To understand this, we have to take a closer look at the kidneys themselves, and we find that they're composed of multiple filtration units known as nephrons. If we zoom in on one of these nephrons, we can see that it's composed of several different parts. And in intrarenal AKI, different parts can be affected and lead to different pathologies. For instance, we could have pathology of the first part of the nephron, which would be an acute glomerulonephritis. Alternatively, there could be issues with the tubules themselves, which would be an acute tubular necrosis. Or there could be a problem with the surrounding space of the nephron, which would be an acute interstitial nephritis. We're going to start by taking a look at acute glomerulonephritis first, and this affects the first part of the nephron known as the renal corpuscle. This renal corpuscle is formed of Bowman's capsule, which is this outer covering, as well as the glomerulus, which is a loop of capillaries designed to increase the pressure. Blood enters the glomerulus via an afferent arteriole, and then exits via an efferent arteriole. And the whole purpose of this structure is to use the thin walls of the glomerulus combined with the increased pressure to drive small molecules out of the blood and into the nephron tubules. To make things easier, we're going to simplify the structure of the renal corpuscle to look like this instead. Again, we have the afferent arteriole, which brings blood in, the glomerulus in the middle, and the efferent arteriole, which takes blood out. The remainder of the tubules and the blood vessels surrounding the tubules we're going to simplify like this. So in essence, we have the entire structure of a simplified nephron here. In acute glomerulonephritis, there's direct inflammation of the glomeruli as a result of antigen-antibody complexes. And these complexes basically bind to the cells of the glomerular membrane, known as podocytes, and damage them, leading to destruction over time. Possible causes behind this disease process include infections such as streptococcal infections or viral infections, as well as autoimmune conditions such as Goodpasture syndrome, IgA nephropathy, and lupus nephritis. To understand the effects of acute glomerulonephritis, we can compare this to the function of a normal nephron. And in normal individuals, there's a good blood pressure, which helps to force small molecules out of the blood and into the nephron tubules. In contrast, large molecules such as blood and protein are unable to pass through the basement membrane, and therefore remain in the blood. If we compare this to acute glomerulonephritis, the damage done to the basement membrane means that there's leakage of fluid, and this leakage decreases the pressure gradient, meaning that small molecules are no longer filtered as efficiently as before. As well as this, large molecules, including the blood and protein, are able to pass through the large gaps. As a consequence of these changes, glomerulonephritis leads to a reduction in the filtration rate, and this ultimately leads to a buildup of waste products in a process known as azotemia. Because less blood is being filtered, we also get a reduction in urine output, known as oliguria. Another sign of the condition is the leakage of the large molecules, which will lead to hematuria, or blood in the urine, as well as proteinuria, which is protein in the urine. Importantly, the tubules themselves are not damaged in acute glomerulonephritis. It's only the glomerulus and the membrane which are affected. To understand the impact of this, we can extend our initial diagram, and we can see that the reabsorption of both sodium from the tubules, as well as the reabsorption of urea, is not impaired by this process. On the other hand, molecules such as creatinine are not reabsorbed into the blood at all, as this is one of its characteristic features. The reason why all of this is so important is because we can measure the BUN to creatinine ratio, or the blood urea nitrogen to creatinine ratio, and because we're getting quite a lot of urea reabsorption, this will be high in an acute glomerulonephritis picture, with there usually being greater than 20 molecules of urea to 1 creatinine molecule. In reality, the serum creatinine will also be quite high because of the azotemia process mentioned above, but it's just that the blood urea nitrogen will be even higher than this. In a similar way, because so much sodium is being reabsorbed, only a small amount is actually excreted into the urine, and as a consequence, we get a urine sodium level of less than 40 milliequivalents per liter in acute glomerulonephritis. Let's now take a look at the second form of intrarenal AKI, which is acute tubular necrosis. In this disease process, there's usually direct damage to the tubule cells which line the nephrons, and more specifically, these are the tubular epithelial cells. The most common cause behind this damage is usually some form of ischemia, so for example, if there's hypovolemia to the kidneys, or stenosis of the renal artery. In other cases, there may be involvement of nephrotoxins, such as aminoglycoside medications, myoglobin, or uric acid, which damage the epithelial cells over time. Regardless of the cause, the hypoxia, or the involvement of nephrotoxins, will result in the death of tubular epithelial cells, and these necrotic cells end up building up in the tubules, resulting in brown granular cast formation. These casts build up over time and oppose the blood pressure of the glomerulus, thereby reducing the pressure gradient and the GFR. Because of this reduction in pressure, small molecules can no longer be filtered into the tubules as efficiently as before. Just like acute glomerulonephritis, the reduction in GFR will lead to a buildup of waste products in the blood, known as azotemia, and a reduction in urine output. However, one of the more unique features of acute tubular necrosis is the development of these brown granular casts, and these can eventually be passed into the urine and detected on urine microscopy. Another key difference of acute tubular necrosis compared to acute glomerulonephritis is that the tubules themselves are directly damaged, which impairs reabsorption. To show this, the dead cells essentially line the sides of the tubules, and as a consequence, molecules such as sodium and urea are unable to be reabsorbed across these dead necrotic cells. As always, creatinine is not reabsorbed back into the blood at all. The overall effect of this is that we get a reduction in the blood urea nitrogen to creatinine ratio, which is usually less than 15:1 in acute tubular necrosis. As well as this, because the sodium is not being reabsorbed, we get more sodium in the urine, and the concentration is usually greater than 40 milliequivalents per liter. Let's now turn towards our third and final form of intrarenal AKI, which is acute interstitial nephritis. And this disease process involves inflammation of the space surrounding the nephrons, or the interstitial space. This inflammation can either be governed by a type 1 hypersensitivity reaction, which is mediated by neutrophils and eosinophils, or a type 4 hypersensitivity reaction, which is mediated by T cells. In both of these cases, the inflammation affects the nephrons and impairs the GFR, so again, substances aren't filtered as efficiently. The most common cause behind acute interstitial nephritis is usually related to medication side effects. So for example, medications such as NSAIDs, penicillins, and diuretics. In some instances, there might be some infections which also lead to an overloaded inflammatory response. Just like in the other cases of intrarenal AKI, the reduction in GFR leads to a buildup of creatinine and a reduction in urine output. In addition to this, the inflammatory processes of the condition can lead to an array of signs and symptoms, including a fever, a rash, and pyuria, which is basically where white blood cells are passed in the urine. In terms of tubular reabsorption, we would get a reduction in the levels of sodium and urea reabsorbed back into the blood, because all of this inflammation basically hinders the normal characteristics of epithelial cells. As per usual, we wouldn't get any creatinine reabsorption, so the net effect of this would be a reduction in the blood urea nitrogen to creatinine ratio of less than 15:1. Because there's less sodium reabsorption, we get a higher level of sodium ions entering the urine, and this is usually greater than 40 milliequivalents per litre. For the investigations of intrarenal AKI, we can look at features such as routine blood tests, urinalysis, and imaging and procedures to help with the diagnosis. Starting with routine blood tests, we can look at the renal profile and the electrolyte levels to search for an increase in creatinine and derangement of electrolytes, so for example a hyperkalemia picture. We can also look at the BUN to creatinine ratio, which will vary depending on the different types of AKI. For urinalysis, we can take a look at the urine sodium levels and the urine microscopy and culture results. And finally, for imaging and procedures, we can perform an ultrasound of the urinary tract or a renal biopsy, which involves taking a small sample of the kidney tissue to analyze which type of condition might be present. In clinical practice, it can be quite difficult to differentiate between different forms of intrarenal AKI, but in exam questions there might be some leading features which can help you get the mark. For example, acute glomerulonephritis is often associated with a higher BUN to creatinine ratio compared to the other two conditions, as well as a lower urine sodium level. Sometimes we can use the unique signs and symptoms of particular conditions to work out the type of diagnosis. So for instance, glomerulonephritis is often associated with hematuria and proteinuria, acute tubular necrosis often involves brown granular cast formation, and acute interstitial nephritis might involve a triad of pyuria, fever, and rash. Again, it's worth mentioning that these are all general statements, and in reality there might be overlap between the conditions. In terms of the management of intrarenal AKI, this largely depends on the type of pathology which is present. For instance, in cases of acute glomerulonephritis, patients may benefit from treating the underlying infection or by giving immunosuppressants. In acute tubular necrosis, it's important to treat any underlying ischemia, stop any nephrotoxic medications, and offer allopurinol prophylaxis for uric acid, especially in patients on regular chemotherapy. Finally, for acute interstitial nephritis, we can again stop the nephrotoxic medications and give antibiotics if necessary. To finish off, we have a summary slide here which outlines everything I've gone through in the video. I hope you find this helpful, and I'll see you in the next one.